Thank you, Joan and Iridex, for having me. We'll have some questions and answers at the end, so we'll have plenty of chance to discuss all this. So again, I'm Ahad Mahuchi. I'm in near Tampa in Florida. I've had this Iridex IQ 577 for a little over 2 years now. And we're going to talk about, I'm a general ophthalmologist who does glaucoma and medical retina, and got lots of different uses for this device. But we're going to talk about treating more patients who, in ways that you can't with conventional laser, more diseases that you can't treat with conventional laser, and how to reduce the number of injections that you're doing in the office. So some more interesting titles that when I first thought of this, honestly, I walked by this booth 1,000 times before realizing what MicroPulse is, and a couple of years later I heard you could actually laser over the fovea, and that's what we're going to talk about today. Something you couldn't imagine talking about, some people still can't imagine talking about now. So some more interesting titles, I think one we had was Honey, I Laser the Fovea, or Can You Actually Laser the Center of the Fovea? Another one is How I Save $20,000 a month on drugs. Another one is How to Avoid Macular Atrophy. Another one could be, can you actually strengthen, rejuvenate, if you will, the retinal pigment epithelium or Bruch's membrane? And then how to do less injections. And all these things are of concerns to general ophthalmologists and retina specialists alike, and we'll go over some of the details. So the nice thing about this machine, it's one machine that treats more patients and more diseases, and we'll go through a couple of different examples of that today. So now I don't gingerly go into it. I've been doing it for 2 years. It safely treats the macula without the side effects of lasers and other drugs. I think a lot of us have noticed that with more and more injections, there's some people who develop atrophy with the retina, and so it's not saying that injections are bad, but maybe we should somehow limit the number that we do to extend the life of them. And in some cases with this laser, we've been able to reduce or eliminate the need of injections for multiple different diseases. So this treats what other lasers can't do. It treats the fovea. So one problem with conventional laser, I'm a type 1 diabetic myself. I would never want a watermark in my vision from a laser close to the fovea. I mean, if God forbid I got macular edema, I would prefer a way to treat it without having to leave a burn that could be seen on microperimetry or any other kind of test. So before, when we just had laser, the injections were good because now you could treat swelling in the center of the fovea. Now you have a second option. You can use the Iridex IQ in MicroPulse mode, and you can treat more vein occlusion patients. Traditional things you treat with laser or injections, now you can have another way to treat the center of the fovea, which we just didn't have before. So it treats some other conditions that lasers can't treat. It's like pseudophakic CME or central serous retinopathy that's really close to the fovea. And we'll go through some examples of both of those. And it treats without the side effects of traditional lasers. You can't simply turn down your traditional continuous wave machine, turn the power down and turn the pulse down, turn the duration down to anything that even comes close to what this machine does. You're going to create a burn that you can see with fundus autofluorescence, that you can see with OCT, you can see with microperimetry, and we'll show you can do the same thing with this machine and none of that happens. And it saves you, the patient, and the insurance money on chronic anti-VEGF drug treatment. These treatments are expensive in the United States. Even Avastin is expensive to do over and over again in your office. The profit margin is little. They've been displacing other revenue for the practice, but a lot of insurances barely pay to cover the cost of the drugs. So this gives you a way to get the same result with having to spend so much money on those kind of drugs. And it's not a laser that does one thing. It does, like an SLT laser only does SLT. This machine you can do, you could use it as a continuous wave machine if you want. If you want to cut a stitch, fine. If you want to create a burn on the cons for something, great. If you want to show off to your kids, family members what it does, great. But in MicroPulse mode, it does MLT, which is just as good as SLT. it does all these glaucoma and retinal diseases. So you've got one machine, doesn't take up a lot of space, that you can treat a bunch of different things, either you yourself or your partners who are in other subspecialties. And we talked about being, if you want to do tears in the peripheral retina, you can use that as a machine to do that in continuous wave mode. So continuous wave, I mean, usually there's not a setting that allows you to turn, you press the laser on, it delivers the laser, it warms up the tissue, it heats it up, and it burns it. That's not what this does. And getting your head around that is honestly something that takes a couple of times to hear, but it applies the laser for a very, very, very small short period of time, much less than what you can turn down your dial to on any other laser. And it never allows the tissue to heat up because it cools off, in most of the cases we'll be talking about, for 19 times the duration of what you just set for a foveal treatment. So it's on for a few microseconds and it's off for 19 times more. It's a lot. So the tissue never gets warm. So my first question when I heard that was, well, then what is it doing? Maybe it's not doing anything. Maybe you're just waving it on the back of the retina. But you'll see that the clinical results show that it's doing something, it's just not burning. It works just in an entirely different way than what continuous wave machines do. So this is what it begs the question, if you can't see the effect, what are you doing? And a lot of people say, can I turn down the power settings and the time settings on my regular machine? You can't. You're going to see, and I've seen other studies will show some, and I've done it myself with microperimetry and fundus autofluorescence. You're going to see a mark no matter how much you do that. Nobody would dare do that in the center of the fovea. So we'll get our head around it's working in some non-traditional way, and then when we hear laser, we now need to think that not all lasers do the same thing. So how does it work? Well, we believe that it works by somehow influencing the retinal pigment epithelium or other tissue in the retina to produce normal intracellular and extracellular bio microhormones and growth factors. And we know from the literature, you'll see 3 references there, when MicroPulse has been done to those tissues, you see upregulation of these normal hormones that may be out of whack for whatever disease that you're treating. So you're doing something different. And perhaps you're promoting a more normally functioning retinal pigment epithelium. So this is one of the things that got my mind to change about MicroPulse. So this is showing the treatment of 62 eyes. This is diabetic retinopathy. And you can see that the laser is not visible like anywhere else. It's amazing. But the foveal sensitivity when you're using microperimetry actually increases. There's no spot where you delivered the laser, and with traditional laser that should wipe out your ability to see the light, but it doesn't do that. Actually, things get better, and that's been shown over and over and over again. So it treats a variety of conditions well. It treats diabetic macular edema, treats macular edema from vein occlusion, it treats central serous retinopathy, it treats pseudophakic cystoid macular edema, and it treats this, and I think this is a game changer. This is like small early stuff, and we'll show you some examples from the edema from wet AMD. It can be a game changer, allowing you to do less injections and having the patient come back less often. So this is my attorney's secretary. So this would give you how confident we are about doing this. She's 70 years old with really poorly controlled non-insulin dependent diabetes. Her control is awful. It's a hemoglobin A1C of 8 to 9. We have coached her to go to gym, go to dietitians, do all this, done all the conventional things, even some non-conventional things like having taken lutein and seeing other diabetic specialists. Nobody's able to do anything, and she's got this edema right in the middle, and her vision's good. On the Snellen chart, it's 20/25, but she can tell you it takes more work to get the same job done. I call it the reading through Jello experience. If you really listen to your patients, they'll tell you, if it took me 5 minutes to read the paper the last year, it takes me 7.5 this year. There's something about the way the fovea is working, and you'll see that The swelling, with MicroPulse treatment, you're not treating the individual leakage. You're treating the whole, you're painting the whole fovea, painting the area that you're treating. Because remember, you're trying to upregulate the entire retina to be more healthy. So you're not spot treating like you are with conventional laser. So you're treating confluently, you're treating a big area, bigger than the area that's edematous. And one thing that you have to understand is because you're not burning and these microhormones take a while, the effect is actually minimal for most of the diseases until month 4. And that's when it starts kicking in. Sometimes at month 3, but you don't expect a lot early on. It takes a while for it to do it. So this is her, 2013 beforehand, and this is 23 months post MicroPulse, but I'll show you some, that's before, that's 4 months afterwards, you start to see it go away. Since that time, I have never done another laser treatment on her. I have never done another Avastin, Eylea, or anything on her. And her hemoglobin A1C is still awful. She's not done anything to improve her sugar control, but the swelling's gone away. That's 24 months, it's about 2 years since we did it. So in the 25 months, actually a little more than since the laser, we've improved the vision to 20/20 pretty early on. Her vision is subjectively improved without side effects as well as being objectively improved. A1C is still terrible, but the OCT looks good. And we've treated right in the center of the fovea something that just can't be done with traditional laser. So here's a central serous case. She's 70, and she had central serous 25 years ago, and she had a recurrence after crystal lens, cataract surgery and crystal lens with me. So what a bummer. She's 20/70. She smokes. She takes the vitamin lutein. This is what she looks like before our focal last fall, and that's 6 weeks after. So not everybody. Central serous kind of clears up earlier than the other things we talked about. It's pretty amazing. I think I've had to treat her with one Avastin since, and she's never regretted it. So for most of these things, about a third of the time, in 2 years, you won't do another injection. In a third of the time, you'll double the frequency, the interval between injections. So if you were, every month or every 2 months or every 3, whatever it was, you'll double it. And then, and then one other category is that there's about a third that will be like once or twice injection a year kind of people. So that's roughly what you expect, but in either case, just because it doesn't get rid of the injections, it doesn't mean that you've failed. You've actually done a good job of not having them come in without needing more injections. There's almost nothing else that works like that. So it's a common clinical scenario that you see that treat and extend works, but then works less well over time. And then eventually you'll see a certain subgroup that fall back to ever shortening intervals. So they're back to every month after you got them out to 3 months. If you're a bit conscientious about it and you think maybe they're getting resistant to one drug, you try to use different drugs. If you're worried about atrophy, you're doing that. So these are all things that you have to think about when doing injections. Your considerations when they're ocular and ocular hypertensive, or maybe you've had a stroke during therapy. It's controversial, but maybe you like to avoid this issue altogether. So now we have another weapon for a two-front war, like politics and anything regular war. Having 2 different weapons is better than just having one. So here's chronic pseudophakic CME. Can't treat that with an old laser. You can't create a burn right in the center of the fovea. She's 72, non-smoker with chronic CME after complicated cataract surgery somewhere else. She was in great physical condition, doesn't smoke, takes lutein. CME recurs and is dependent on steroids and Avastin for years. Non-steroidals are not that helpful, and things have drifted to 20/70. Before the focal, her didn't really look too bad, right? But that amount of edema was enough to goof her up to 20/70. So this is one example. Most everything is done like this. We do a test spot at with conventional wave somewhere not important, 100 microns, 1/10 of a millisecond. And you usually start at 50 and you go until you see something and turn back. And then I can give you the math. You'll double the size of the spot, double the duration, and quadruple the power, but then go to 5% duty cycle. There's no study that shows that 5%, at 5% you're not going to do any damage by creating a burn. At 10% you can. You can see 10% spots sometimes, but you want to stay at 5% in the fovea. So we stopped the steroids and have given her no supplemental Avastin since we've done this, and now she's 20/25 vision with no steroids or Avastin for the last 5 months. When I wrote this, it's now 14 months. So that's, you treat the swelling and more. You try to get way beyond the treatment. So I'm assuming that that retinal pigment epithelium so the retina is sicker, not just in the area that you're treating, but somewhere beyond it.
Is it a standard pattern you put across, or just where the swelling is?
I'm sorry. You want to?
Sorry.
You can fluently paint. The question was: do you spot treat, or do you treat just the areas that are swollen, or do you treat beyond that? And you treat beyond that, and you treat confluently. You paint each of these spots. And it doesn't take very long at all. And with Texel, it's crazy fast. It's really fast. Yes, sir.
The spot size was 100 micron.
Oh, I'm sorry. Let me. Okay, go ahead.
The spot size was 100 micron. The test spot size was 100 micron, and the duration was 0.1 second.
Okay.
Okay, you can hear me?
Yes, I can hear you.
The spot size was 100 micron, and the duration was 0.1 second or 100 millisecond. Okay, this is the test spot size.
That's the test spot.
And when you started the treatment, you
Went to-
doubled the size of the shots, and you doubled the duration,
Yes.
and you tripled.
Quadruple.
No, this is triple.
Oh, I'm tripled. I'm sorry.
This is triple.
Tripled, yeah, but it's usually quadruple. Sorry, that's got to be a mistake. Yeah, so
So it's 360 milliwatt?
it'd be 320.
Huh?
320.
320?
Yeah, 320.
This is not 140.
Yeah, not that. It's quadruple though.
Okay, let me say something. When you are testing on 100 micron and the laser marks on the retinal surface, when you increase the spot size, this power may not mark. So I think it's better to test with the 200 micron, with not with the 100 micron.
And people do it. There's a considerable group who do it that way. But if you do it I did the energy math once, you'll see that you'd have to, with doing it the way that I'm doing it, you'd have to hit the same spot 4 times in order to see any change. So it gives you a huge safety margin, and it's doing it that way. Either way is probably okay. I don't see anybody saying there's a difference between it. But when you go, the real big difference is the MicroPulse is going to turn the energy way down where you can't create it. You don't really see anything. Once you go to 5%, you're just not going to see anything. Even if you hit it 4 times in a row, you're not going to. So it gives you some leeway to paint.
Okay, another question please. If it didn't mark on 80 microwatt, what you are going to do? You are going to increase the power?
I go until I see something.
Yeah.
And it's usually going to be between 50 and 100. There are people who don't do the test spot. They just start with, they assume 70 is or 80 is the spot. There seems to be just such a wide range of safety that you're not going to have to worry too much about it. I just still do it the old way because that's the way I learned to do it. So.
I think we have to consider the difference between people as regards the RBE and as regards the lens status.
If you don't create a burn, again, the MicroPulse is the big change. The doubling in size is going to reduce the power per laser by a factor of 4. The duration of time should cut that in half, but then the safety factor is a factor of 2. But that's not what you're looking for. It's the MicroPulse that dramatically reduces the kind of. It's the MicroPulse is the issue, not any of that other stuff.
I'm sorry, but when you're, you saw that first example of somebody taking 24 months for the swelling to go away.
It didn't take. It took 4 months, and I was showing you the 24-month follow-up.
Okay, so that's my question. So, is there a period of time where you'll say, okay, I think we should retreat now because we just have not getting response?
It's not very common. I think for the tougher diseases, I'll show you with like AMD, I've done that at 6 months. But it's rare in the first year. Like to have a complete failure is after one round. I'm going to put it under 4%.
So for that complete failure, what's the outside point where you define it a complete failure? Would it be 4 months? What you're saying?
I'd say, yeah, 4 months. I'd say if I don't see any reduction in swelling, I don't see any subjective or objective improvement, I consider it a failure at that point.
And is that a failure, or is that an opportunity to retreat?
Most of the time, it's more an opportunity to retreat. But generally, if they had responded to one of the practical part of it is your patient probably wants to see better than. So in that you go ahead and give them some anti-VEGF, and then try to retreat a couple of weeks later to see what the effect of the anti-VEGF is, and then add this so that you're not having to do that injection over and over and over and over again. So, okay. All right, that's very good. Those are good questions. This is 4 months after the focal for her, and as I said, it's 14 months or something like that, and we haven't had to do too much else. So can we get away from repeat injections? Of course, newer pharma studies suggested that most of us don't actually do what's on the label. That's no surprise. There are practical limits there. Patients often get tired of doing the robo injections over and over and over again. And there are undesirable effects after multiple injections. So sometimes the pressure can go up, not that common. But atrophy, you can't be in this business and not see that there's some people, maybe a third, who have these injections like 3 or 4 years later that you're starting to see it. And I've heard people argue, well, that's just dry macular degeneration progressing under the wet macular degeneration that you've somehow stopped. But you see it in diabetic patients who get robo-injected. You see, it's not just, and in my practice, the other doctor, I had another physician who wasn't doing MicroPulse and was still doing the injections. You see that the rate of atrophy was much higher in his in the same practice. So there's got to be something else going on with these. These drugs are great, but there are side effects that we need to watch out for. So, cost, frustration, tachyphylaxis, and side effects give you atrophy, or all issues. But atrophy is just as bad as fluid. Any way that the retina's not working is bad. So you want to, if you can avoid fluid, great. If you can avoid atrophy, even better. So this is relatively new stuff. This has gone on for about a year or two, but a year and a half. We see that atrophy can give you slower reading speed, definitely like the reading through jello thing. It can cause water spots in the vision. You can definitely see this on microperimetry. And no matter how about what the cause, from geographic atrophy or atrophy secondary to chronic anti-VEGFs, neither is good. But we don't have to stop using anti-VEGF drugs. We just need to find a way to minimize them. So if you stop it, that's great. But if you can double the duration of time or triple the duration of time until you get that atrophy, you've done that person a favor. So MicroPulse is an option. It works in patients who are unresponsive to anti-VEGF therapy. It works with patients with good vision. It works without the glaucoma, pregnancy, and stroke concerns. It reduces the number of visits to your office, and there's no fear burden of as many repeated injections. So I stumbled into this. I had somebody who had a vein occlusion and had a scar, and I felt free to treat the fluid. I noticed that the side that the branch retinal vein occlusion, the other side that wasn't affected, the AMD-related fluid started to go away. So they're like, lucky find, right? So then the patient's not out, vision haven't threatened her with anything. So then you just realize that it's starting to work on other patients. So here's one. He has lost one eye to wet AMD 10 years ago. We've put him through a smoking cessation, Preservision, 20 milligrams of lutein, fish oil. He develops wet AMD in his other eye in 2010 and has had 31 injections. And the intervals are becoming shorter, and he's starting to feel the ship sink in the same way that have the result in the other eye. So he gets to 20/40 in his only good eye, and he's really miserable. So I think that's what he looks like. We do transfoveal MicroPulse at 5% duty in January of 14, and fluid remains in May, so I repeat it at 5% duty cycle here. So by September, his vision's 20/25. No injections in 9 months, and he only had one injection in 2015, and that's still true today. So that's not random. I mean, I'm sure that somebody would say that, okay, that's N of 1, but I have about 300 patients like this that I've treated. I wouldn't have that good of a role at the blackjack table doing that. So.
These are patients with subfoveal edema.
Mm-hmm.
So,
or intraretinal edema.
Intraretinal edema, but
or some subfoveal in some
subfoveal
cases.
edema.
Mm-hmm.
Right. So are you just doing you're pasting across the fovea too?
Right across the fovea.
And so how many spots are you trying to accomplish in that area?
If you, like with Texcel, you do a 7x7, so you can get 49. I think you're in that 150 to 250 spot, depending on how sick the rest of the retinal pigment epithelium looks.
Is this a pattern that's unique to you? Is there a set pattern that Iridex recommending, or?
You want to paint confluently all the sick areas. Originally, I didn't have a Texcel, and I just manually did it, and you can do it that way. It's just a little faster with the automated delivery device. And this guy's situation is pretty typical. Like, there's about a third of people where you've got it down to one injection a year. And that can happen without doing MicroPulse, but it's not that common. And so that's why you have a run of 300 patients doing this. It's pretty amazing. So it's foveal friendly. Again, with high intensity laser, you are creating burns that are separated. With smaller spots, I guess you're doing all this stuff. With low intensity, that's probably what you're doing. You're creating a smaller burn, but here, you're treating everything. I mean, you're painting. You don't want to leave a spot untreated. And remember, you have about a factor of 4 at least that you feel comfortable about treating over an area. I've never had anybody who had a negative outcome. So second AMD case, 70-year-old develops wet AMD 3 years after cataract surgery despite being on an AREDS protocol and more. His vision varies from 20/40 to 60 on a Q6 week Avastin, but the fluid's getting harder and harder to eliminate. This is a very common situation. So we do transfoveal yellow MicroPulse laser in January at a 5% duty cycle. No injections in 9 months. Actually, he hasn't had an injection all of 2015 either. His vision stays, it bounces between 20/30 and 20/40. I just saw him recently, and no side effects. 3 weeks after the Avastin, you can see the subretinal membrane kind of fibrotic there, fluid, a little bit of subretinal fluid. But 8 months post-op, he's not perfect, but his vision's better, and he hasn't required another injection. There are people with repeated injections where you never get rid of all the fluid. So it's success in chronic disease. You may need more than one treatment, but it's not common. You may just stabilize the OCT, not perfect it. You may reduce but not eliminate the anti-VEGF treatment. And you may achieve a stable vision in OCT without the cost and atrophy associated with repeat injections. So, and you've got a financially better situation for you, the patient, and the government, insurance, except the drug companies, I guess. So again, the yellow MicroPulse advantages, you can safely treat the fovea at a 5% duty cycle, not a 10% duty cycle. It does not harm, it doesn't leave watermarks or a microscotoma in the vision. It's easy to administer, and it's got great insurance coverage in the United States with allowance for profit, as opposed to pass-through status for the drug. So it's not a one-trick pony. As I said, I do glaucoma as well. And so with ALT, you're creating little burns. With MLT, It's done very similar to SLT. It takes about maybe 140 spots around I do 360. I think there are other people who do it differently. And it works about 80% of the time. And its advantage over ALT is that you can treat patients without trabecular pigment. So that's a big advantage. That's supposedly the advantage of SLT, right? So the volume of patients you can do now doubles over what you could do with a traditional argon laser. The advantage over SLT is there's no pressure spikes. So pressure spikes are rare, but happen. Not that rare with SLT. Never had one in 2.5 years or about 2.5 years of owning the machine. Yes, sir.
One of the strange side effects of an SLT is corneal edema,
Never seen
essentially, which I've gotten with, and you've never seen that.
I've
with this.
never seen that. I've never seen that. It's 80 to 85% response. You can retreat it with. I've had somebody who was like 14 months out that faded a little bit. I did it again. Their other device, the G6 P3 probe, is another another way to treat glaucoma, but it's not on this device. So you can use it in traditional mode for traditional ALT if you wanted to do that. You could treat retinal tears, cutting sutures after trabeculectomy, whatever you like. You need it. It does what other lasers can't, and it treats diseases that other patients can't. And that's important. So I learned about Cyclo G6 with the P3 probe, so I'm just going to tell you a little bit about it. Yes. Oh, sorry. I don't hear it.
Excuse me, can you tell us about the parameters in the MLT?
Yes, it's 300 microns for 0.3 seconds, 1,000 milliwatts. 0.3, 300, 1,000. Rarely you will need to turn it down to like 900.
MicroPulse is
15%, sorry.
15.
Good question. 15, yes. 15.
15%. Yes, thank you.
So occasionally you'll see something in the trabecular meshwork, but most of the time you can't.
The spots are adjacent to each other.
Originally, I didn't do it adjacent. I've heard other people have been more successful. That's everyone else is doing it adjacent. I didn't for the first year and a half. I'm not sure there's a difference, but I'll find out, I guess. You still get about 85% of people have a great response, whether you do it adjacent or you have about a spot size in between.
360 degrees.
I treated 360, and I'll do both. I have no problem doing both eyes with it. I mean, in the United States, you lose a little bit of money, but you're not gonna. It's just for an efficiency thing. It helps you get through the day. The repeat visits are less. So it has so little negative side effects. There's almost not a reason to skip doing it.
There is no instantaneous reaction like bubbles or something like this?
No. Like an ALT, yeah, sometimes you look for those little bubbles. You don't see it with this.
Thank you.
Good. All right. Cyclo G6. Cyclodestructive procedures have been around for a while. You could do cryo, you could do laser, and you get less and less inflammation as the technology gets better, but you really only do these procedures for blind, painful eyes. So some very clever people figured out several years, more than 5-6 years ago, that if you use MicroPulse laser treatment through the sclera, it took me a while to get my head around this. It's not an inflow procedure. It's actually an outflow procedure. It improves outflow. So I'm sure everyone has your 90-year-old patients who don't really want to do a trabeculectomy on, even if you're really great. They're on blood thinners, or they can't afford the drops. They're now allergic to alpha-GAN, can't take, they get CME with latanoprost. And you build up these patients over time. So I asked around the country for people who had done this and internationally how comfortable they felt with the recovery. And it's quite amazing. You treat, in 3 minutes, you treat 360 degrees around the ciliary, the limbus essentially. Very short learning curve. If they're blocked, super easy. If they're really elderly and you don't want them to, they don't need to be blocked, they're not having cataract surgery or something else, you can I started out doing bilateral treatments. So you give them a little cocktail of Versed, a little fentanyl, and just one dose of propofol. And you can get 80% of the time, that's all they need. You get through the 6 minutes of treatment, and they're up and talking in usually about 6 minutes, even the 90-year-olds. So I sent Iridex a picture of a video of one of the patients was reading just a few hours later. There's no inflammation, nothing. I've eliminated the first day post-op. It's just unnecessary. So I'll give them steroid, pred, 2 or 3 times a day for the first 2 weeks. Okay, so I stop one of the glaucoma medicines at week 1. I stop the steroid at week 2, and you see them 3 or 4 weeks later. And so far, I think I've done about 40 eyes. 1/3 of them will have a lower pressure on one less medicine when you see them in that 3 or 4 week visit. About 1/3 of them will have the same pressure on less medicine. And then 1/3 of them didn't follow instructions for me, and I'm not really sure what happened with it. So we'll find out with longer term. But it's got, a lot of people are asking about duration in the United States. Maybe people only have a year of experience, and then I'm seeing it's lasting. I've asked in Singapore, and they're saying that, and for those people, they started with pressures in the 40s, angle closure, that kind of stuff. Mine wasn't like that. Mine was typical garden variety, open angle glaucoma, 40 pressures in the mid-20s, even to high teens. You're just trying to eliminate drops. Works great for them. Probably in the paradigm of where you're going to add this, it gets right, can be early or as something to do to avoid trabeculectomy in high-risk patients. No intraocular maneuvers, so that's nice. No need to stop blood thinners. It's an outflow procedure, and it's great for reducing drop usage, like we talked about. And there's really no need to see them on post-operative day 1, unless your insurance company requires it because they were blocked. That would be the only. For combined cases, I'll do the procedure and then do the prep and do like cataract surgery second. So maybe a way to go to avoid trab, and that's it. If there are any questions, I know that covered a lot of material.